Our first presentation is going to be Prescribe to Save Lives by Dr. Alexander Wiley.
Great. Thank you, Shanice. Now, do I just tell you to flip the slides for me?
Yes.
All right. So I'm going to start. It's really a pleasure to be here and share what we've learned. So the name of our project is Prescribe to Save Lives. My name's Alexander Wiley. I'm at Boston University School of Medicine. I'm a primary care physician, HIV primary care provider. Also see patients on our inpatient addiction consult service at Boston Medical Center. And I do research on overdose and integrating addiction and medical settings, which is what this study is about. And Unity was one of the sites. So next slide, please. By the way, I have no commercial disclosures. So by way of background, people living with HIV have high rates of opioid use. Overdose is a significant and growing cause of preventable morbidity and mortality. And HIV outpatient practices are provide an opportunity. They're promising settings to intervene to reduce overdose and treat opioid use disorders. There's been modest success of prior attempts to introduce office-based addiction treatment with buprenorphine, which is one medication that treats opioid use disorder and reduces risk of overdose. Next slide, please. Thank you. So the objectives of our project, the study aims, was number one, to improve the acceptability and readiness to prescribe naloxone and buprenorphine. So and for this aim, our target is really our prescribers. Aim two was to increase the number of HIV clinicians who prescribe naloxone. And aim three was increase the number of HIV clinicians who receive training and waivers to prescribe buprenorphine or office-based opioid treatment. Next, and we're funded by NIDA, by the way. Next slide, please. The intervention components were to leverage the value of, quote, saving lives to implement naloxone prescribing among HIV providers and motivate them to adopt office-based opioid treatment. So we had a clinician-led peer-to-peer 90-minute on-site training. I was the clinician peer-to-peer trainer that came to Unity back in December 4th, 2018. We also had written materials, a brief lecture, discussion, demonstrations, and a role play. There's also a proactive expert support and post-training mentoring. So there was reaching out to the clinician trainees within 2 weeks after the training via telephone and quarterly via email during the implementation period. We had academic detailers who were coming in. They were either a nurse or a pharmacist trained in motivational interviewing who came to Unity and did manualized detailing visits at 1, 3, and 5 months after the initial training. And at Unity, it was Mary McCormick, who's a PharmD, who came in early 2019. We tried to address environmental barriers, working with local pharmacies to make sure they were stocking the naloxone and the buprenorphine. Next slide, please. So Unity was one of 23 states, 18 states, of course, District of Columbia. So every region of the contiguous United States was represented. We had between 5 and 29 total participants or prescribers per site, 293 total participants, 122 were prescribers, and 171 were other staff. There were 287 participants at baseline, and we had 79% overall follow-up, 76% in the prescribers, and 82% in the other staff. Next slide, please.
We're at 1 minute.
Next slide, please. My time is valuable. It's getting chewed up here by the pause between slides. I'm sorry.
I think there's a delay. Sorry.
Yeah, so that's okay. So here's some preliminary results, which essentially showed that interest in prescribing, especially with naloxone, confidence in prescribing with both buprenorphine and naloxone, readiness to prescribe for both buprenorphine and naloxone, and commitment to prescribing with naloxone all went up after the intervention compared to before. Next slide, please. And I'm going to have you click through several slides. Well, I'll try to do this quickly. There were barriers to prescribing naloxone, which we picked up on qualitative interviews we did among 15 of the prescribers. There was resistance from community physicians and patients, stigma due to naloxone being seen as enabling continued drug use. Patients and their families were in denial regarding their overdose risk, a lack of resource and time during visits, a lack of awareness, insurance, geographic accessibility. Here's one quote: 95% of the first responders that I work with refuse to give it because it's enabling. It's enabling their behavior, and they're just going to continue to use. Why should we support that? Next slide. Barriers to prescribing buprenorphine. So lack of prescribers due to the certification process. There's still a lack of time, resources, and support, and this feeling among some just not wanting to deal with those patients. There's an increasing number of prescribers who have a waiver to prescribe buprenorphine, but I think that's insufficient. I think a lot of prescribers aren't going to prescribe it because they feel they don't have the counseling support and other wraparound services that people need. It's not clear that healthcare organizations or individual clinics have resources for that additional piece. ASAM has trained, I think they said 90 people in this state to get their data waiver. Of those, they've trained only 6 people are actually using it. By the way, this is undoubtedly not the District of Columbia, but one of the other states. Okay, next slide, please. I'm going to skip this slide and go to the next slide just because of time. And one more, and we'll just go to the end because I know I'm out of time. So next steps are for us to get secure EMR data to complete our primary aims analysis, to determine the best graphical displays of the data for our papers, and identify additional research questions, how to use the data collected from non-physicians. Next slide, I think I'm done. Yeah, I just want to thank the research team. It's a large team, and most importantly, thank Unity and your participation in this project, which is ongoing. And I'll stop there. Thank you.
Thank you so much. If anyone has any questions, please send them to the chat. We do still have a few minutes left to discuss. Oh, we do have one question just before we get going. Is there any literature showing how to successfully overcome some of these barriers?
Yeah, great question. There are some around buprenorphine, which really are, resourcing the clinics and the providers appropriately. I think I'll just tell you, not just from the literature, but also from my own experience, that doing office-based addiction treatment with a multidisciplinary team where you have, if you have that available to you, which most community health centers do, is very helpful. And so, yeah, I think, part of the reason we were funded to do this study is there wasn't enough literature, but there's some indications that, the more you invest in programs to support this, the better off you are. And so this study was trying to do some of the concrete things that it would take in order to facilitate. I see also that there's a request to share my slides and resources for implementing a successful program. Yes, we can certainly share our slides. I'm just going to type in the chat a website that has some resources for implementing successful buprenorphine program. That's bmcobatta.org.
My name is Dr. Anamwine. I'm a family medicine physician here at Unity Healthcare. I work at the Parkside Clinic. And I'm also core faculty with our National Family Medicine Residency Program. You can go to the next slide. So this March in 2020, we had come up with a proposal that we wanted to implement called March Safety Madness to increase and promote quality improvement in patient safety among our entire clinical staff and really amongst our patients also. We wanted to emphasize how everyone is part of our healthcare team, including the patients themselves. And we wanted to do this through competition and trivia throughout the month. I'm talking a little, my tenses are going to be a little bit different because, as you guys know, in March, COVID hit. And so our plans were put on hold, but we wanted to present this because we are hoping to do this again in March. And then also to give other clinics ideas and hopefully expand this and take this further throughout Unity. Next slide. So we had bracketed this as a competition, and we had 3 quote unquote regions that we selected winners from. We had a QI, a policy, and a patient safety quote region. In our QI selection, March is Colon Cancer Awareness Month, and every March at Parkside for the last couple of years, we've done colon cancer competitions amongst the providers. So we included that as part of one of our as part of the quality improvement that we were going to do this month. So between the first 3 weeks, the highest number, the quantitative number that a provider got for colon cancer screenings, either via colonoscopies or FIT tests, were added up, and the one with the highest number would win from that bracket or that region. We also had a policy selection region where we focused on our clinical staff, and they delved into the health policy. As we know, that's a very crucial part of patient safety and our patient care, to know the policies that we have at our clinic. And so the PRCs, the MAs, the care coordinators did head-to-head competitions, and there was going to be a winner amongst that region. Next slide. Then our third region was going to be for patient safety during a selection week. We would email out daily information and tasks to do. The first part was taking the pledge, and actually this started on the first day of March, or we would have started this on the first day of the month, and included both patients and the clinical staff, and I'll show you the pledge that IHI promotes in the next slide. But we also did a day where we advocated and taught and empowered our staff to file incident reports. We sent an email talking about the importance of hand washing and attached a quiz to it for them to return to us. And then we also had an email talking about the importance of communication, and their task for that was to send us examples and incidences of communication that they noticed impacted patient safety in a positive or a negative manner. And then on Friday, we wrapped up the week by talking about root cause analysis and the importance of that in patient safety. And with that, we really wanted to both educate all of our clinical staff on what a root cause analysis is, and also empower them to do one on the incident report that they had filed, so that they took the next step and not only identified areas of improvement that we had in patient care, but also gave us their input and their insight on how to improve it, and so that they felt part of the team and part of the improvement process. And then all of the 3 winners from these 3 regions would be participating in a championship Jeopardy game at our meeting that's on the 3rd week. Next slide. And I'll actually end on this slide, and I think it talks about the different themes that we're probably going to talk about with all the posters. We really wanted community buy-in. We wanted the staff and our patients to really understand that they are all a vital part of our patient team-based approach at our community center, and that our patients, we wanted to advocate and empower them to take an active part in their healthcare team, encourage them to ask us questions and participate. And we wanted to remind the entire clinical staff that we are all healthcare professionals, regardless of where we are on the team, and that we are all taking a pledge to really help and improve our community's care, especially a community that's often overlooked, and their concerns and their thoughts and their perception on their own healthcare are very biased. And so we really wanted to get a whole clinical input and kind of promote collegiality and competition that hopefully generated some excitement. And we hope to do this in March. Hopefully COVID takes a little break and goes away. And then hopefully by next March too, we're hoping that we can expand this to other months and kind of continue improving on other quality improvement and other aspects of our healthcare community.
Thank you, so much. Our next presentation is going to be Point of Care Lead Testing at Unity Healthcare by Rachel Gugian.
Okay, hi everyone. So just to introduce myself at first, I am Dr. Rachel Gugian. I am family medicine, primarily at East of the River. And I am presenting today on this DC-AAP quality collaborative that will bring point of care lead testing to most of Unity's clinics. So we can go to the next slide. All right, so this is a, like I said, collaborative effort. DC-AAP approached our clinics, and at first there was a pediatrician colleague of mine primarily working on this in 2019 to bring these lead care to point of care lead tests to the clinics. The goal is to increase the rates of lead screening in our communities. And these kits now, after being kind of slated to be rolled out, should be coming towards these end months of 2020 with a training for MAs scheduled as early as next week for some MAs. Next slide. Okay, so this might be good background information for some people, but it might just be an overview for others who are very familiar with it. But exposure to lead can cause hazardous effects on a child's body, especially the brain, blood, and kidney function. So obviously finding exposed children early can help to prevent any of these serious developmental delays, cognitive deficits, behavior issues, and so forth. And by finding any one child, it's like finding a sentinel event of being able to then screen other children in that same family, same school building, same perhaps public housing building. So it is very important to be finding any positive cases. The other reason why we do lead screening is it's a requirement for DC public schools and daycares. More recently, the school forms have been explicitly asking for 2 tests for lead, with the recommendation being to test each child twice by the age of 2 years old. And then finally, I've just written, it is a strong recommendation of the American Academy of Pediatrics, the CDC, U.S. Preventive Services Task Force, DC Health. Next slide. So in terms of the guidelines, the first screening should take place around 9 months to 15 months of age. The second screening should take place around 22 to 24 to 26 months of age. If a child's missed those 2 screening opportunities, it should be repeated twice before the age of 6. And then, of course, any other child that's been exposed should be screened regardless at any age that test can be ordered. Next slide. Okay. So the advantage of doing point of care tests. So as anyone that takes care of children know, it's a lot easier to do a quick finger stick and capillary sampling than it is to do a lab draw. It's great to be able to do same day interpretation of the results. And for a lot of us, that can mean less chasing down and doing phone calls to find the parents to discuss lab results. And then overall, just fewer opportunities for missed screenings, which would lead to higher quality scores for Unity. Next slide. This is a quick overview of the MA workflow, which would add the lead screening, and that'll be discussed with MAs. Next slide. Here is a quick overview of lead levels and interpretations. I just want to stress a lead level of 5 or greater would go to the DC DOH Department of Environment. They would reach out to the parents to discuss that result and offer everything from cleaning products to actual treatment, depending on the level of toxicity. And then next slide. I've just included some links regarding lead in the district, and a reminder that parents could sign up for the lead screening by texting. They would get reminders, and the phone number is here. And then finally, any questions? We can go forward to the next slide.
Thank you so much. If you have any questions, please put, and we'll wait a few minutes for any follow-up questions. Thank you so much for your presentation.
Of course. The one question I'm expecting to answer is many people would want to do hemoglobin testing on the same day. Those are the two labs that are frequently ordered for young children. And there is a point of care hemoglobin test that's available that's currently used by WIC. And those hemoglobin tests are required at least one time in a child's life. So it is possible to working on ideas on how to involve that as well. And have elevated levels been identified?
We do have two questions.
Yeah. So the capillary tests this is a Laboratory Association of America approved test. So I believe that the specificity and sensitivity of these was high enough that it was it was a reliable test to do point of care. But I don't know exactly compared to the venous blood draw what those numbers are. And then have any elevated levels been identified? So using this point of care in our clinics, we've not yet fully integrated it into clinics. I don't think any yet using this method, but absolutely, I can even say I was surprised to see a child just a few weeks ago with a lead of 11, and I did go through the process with contacting DOEE, and that family was provided like cleaning supplies. I think the house was like 120 years old, so they were able to have that concern addressed, and I'll be bringing that child back soon.
Krista noted that it makes her think of point of care HA1C versus blood draw, and the difference we see. Sounds great though. Looking forward to seeing it rolled out at the clinics.
Agreed. Yeah. Similar to point of care HIV testing as well, which can be a real way to break that barrier for some people who don't want to go to the lab. Okay, thank you all.
But I'm a family nurse practitioner, and I'm one of the site leads for ISAC 4, and I'm also the director of the Advanced Licensed Practitioners. Excuse me. And I am going to be talking about what we're doing at the ISAC site. And I also want to let you know that I am not a statistician by any stretch of the imagination. So a lot of the information I am going to present today is very rudimentary. If we can forward. So one of the questions that I wanted to actually ask, and it's still early on for us to ask this question, but to start thinking about it, is do the patients that we actually see at ISAC have more positive test results, more positive corona test results versus the general DC population? And so the reason why we bring this up, and the whole reason why we're doing having the ISAC locations, and we can forward one slide, is that we all think that the homeless populations are at more risk of contracting COVID. So I'm sorry, Shanice, if you can move one slide forward. Okay. So what the ISAC hotels are, they're hotels within the city for isolation and quarantine for anybody who has basically no place to go. If they're in the shelters, they can't quarantine safely at home, they're on the streets, or any other situation where they could not safely isolate or quarantine themselves. When we first started, I think we had 4 sites, and then we opened up one more, excuse me, and now we are down to 1 location, which is Skyline Hotel, which does have a maximum capacity of about 200 rooms. And we can move forward a slide. And so you probably can't see this very well, but what it's showing you is that this is our census over time. And you can see it really much corresponds to the surge. And then we have that second bump later on in the past month. And we're kind of seeing a leveling off, which is an interesting thing, because it really does mirror what's going on in DC in general, which I thought was kind of interesting versus a big spike in that it stayed elevated. So we can move to the next slide. And actually we're gonna, oh, perfect, I already moved them. Okay, so the biggest questions are, what are our infection rates? And so to make it easier, because believe it or not, finding infection rates is a lot more difficult than you would imagine. And so what I did was I actually collected information based on test positivity rates in comparison to the total populations of that particular area. So I'm actually going to start at the bottom of the list. And right now in the United States, the test positivity rate is about 5%. And so that's from the past week. And so we have seen a big decline in the positivity rate, which actually is about the same for DC in total. Right now, I think it's listed as 5.5. And a lot of the other populations that I have listed on this slide are really difficult to find. And so the one that I'm going to point out, which is not a great statistic, but it's something to give us some information, and the homeless populations in Atlanta, San Francisco, Boston, and Seattle during the surge in March and April listed a positivity rates of 18 to 25%. So that's huge among the homeless, or among any population really. But that was during the surge. And then trying to find the information for the positivity rates now is going to take a lot more doing. So I wasn't able to really dig into that information, as well as trying to find information for positivity rates at other similar programs across the United States. So DC is unique, but it's not the only large city that has a homeless ISAC program. And so
1 minute.
And so the ISAC location in DC, the big question here is, what's our denominator? And so in looking at using all of the people who have stayed at a hotel as my denominator to start, it was it was almost 1,200 people, but having to remove about more than 300 of those because they either weren't tested or didn't have lab results that were available. I couldn't really say whether or not I could include them into the denominator because there's nothing to compare them to, whether they're positive or negative. So I removed those. So I ended up with a denominator of 830 people who actually got tested who were at ISAC. And so if we look at that number by itself, we have a positivity rate of like 47%, which is huge. But that's only the people that have been at ISAC, right? That's not everybody in the population. So if we add everybody who was admitted to ISAC, even if they didn't have lab results, it comes out to be 34%, which is still huge. Okay, so if we add in all the people that stay at shelters, in addition to the people, well, not in addition to, including the people that were at ISAC, we increase our denominator to about 3,500. And that is a big guess because, believe it or not, that's another big question mark of a number. But then we decrease our percentage or positivity rate to 11%. So we're getting better. But then if we look at the total homeless population from the last count from January, that denominator goes up to 6,300 people. And then our positivity rate now is 6%, which is crazy because that really does mirror a little bit closer to the national average, which again is something to really compare, but it's hard again because we're comparing apples and oranges, because the 6% is over the complete time of the time that we've had the ISAC program available versus just the last bit of the positivity rates from the last week or so that's been reported nationally and in DC. So we're still not there yet, but we're getting better as far as our knowledge of what we have going on in our homeless population here in DC. And so if we can forward a slide.
I just want to say
So
we
what
have
we know
about,
and what we don't know.
and that
Okay.
includes questions.
Perfect. Okay, so lots of issues, lots of questions as far as if we're really making an impact. And if you just look at those basic numbers, it does look like it, but there's a lot of questions along with that. So, you know, again, what do we need to include in that denominator to really ensure that we're counting everybody? And then some people come, they don't complete their quarantine time. Does that really have an impact, particularly if they are positive, because they're going right back to the same community where they can be infecting other people? In the early days, we had a lot of people that weren't tested as we were following the CDC guidelines. And if they weren't symptomatic, then they didn't get tested. But we all know that that's not always the case. We have lots of people who are asymptomatic and do have coronavirus. And then the reliability of the testing can be an issue. So really, there's a lot more issues, but I'll save it. So the big things really are that the ISAC curve really does mirror DC curve. So I think that's really encouraging. And then there does appear to be, this is observational information here, that the we've really seen a decrease in the number of positive tests lately. And that we really do have a relatively low number of people who actually get hospitalized specifically for coronavirus. But it does also not always take into account the different milestones of, like, when one hotel opens, another one closes. Now we're moving to opening a new PEP V site, which is our kind of sister location for people who are negative but are highly vulnerable. And so moving forward, really the biggest thing for us is to really start to think ahead as we develop systems to really gather data in a more meaningful way, because, you know, as we all know, we had no idea this was going to last as long as it did. So we really didn't have systems in place to really gather data as we wanted or even thought about as we move forward. So we can move forward a slide.
Thank
And
you.
just
I'm
thank
sorry,
you.
Barbara. Thank you so much.
That's it. That's it.
You have a lot of rich knowledge to share. I do want to say that if anyone does have questions they'd like to ask specifically about this presentation, please do put them in the chat box, and we can collect those and make sure we get answers back to you. Barbara, if you see any, please feel free to respond directly to the message in the chat.
Absolutely.
If you can stop sharing your session, and then we will move on to our final presentation. You guys have been great so far. We may have a few extra minutes to revisit some questions right at the end before we move on to the keynote. I think this will be a nice segue into our keynote, Addressing Systemic Racism at Unity Healthcare by Dr. Krista Chapman.
Hello, everybody. Good afternoon. My name is Dr. Krista Chapman. doc and the medical director at Parkside. And today I'm going to be talking to you all about addressing systemic racism at Unity. Next slide. The last few months have been really tough for the Black and Brown communities. On one hand, we have COVID-19, who's killing us at a disproportionate rate. And then on the other hand, we're fighting the injustices of systemic racism and police brutality that have ended the lives of Ahmaud Arbery, Breonna Taylor, George Floyd, among so many others. Next slide. June was the month the sleeping bear of social justice and advocacy woke up in so many of us. We reflected, we protested, we marched, we virtually gathered, and started to make some change. Next slide. The middle of June, the Social Determinants of Health QI work group shifted its focus to address systemic racism. Next slide. And in our first strategic session, we focused on making an issue tree that at its base holds the high-level issue that our patients have worse health outcomes due to the effects of systemic racism. We broke it down into 4 branches: the quality of care that's provided, the research behind our practices, barriers and social determinants of health, and addressing the healthcare workforce. So it's really important to note here that not only did we look at additive measures, such as implicit bias training, but more importantly, looking at subtractive measures. So those are things that we're currently doing that we can take away to improve the outcome for our patients, such as using race-based calculations. Next slide. So this slide is really busy. Don't freak out, just walk with me. And I'm gonna give you the highlights. This is our execution and solution part of the tree. So our first branch really looks at the substandard of care that's provided to our patients. So we want to hold our referral partners accountable for best practices, but most importantly, we have to fix our house first. So that starts with looking at the points of entry that patients access care and ensuring that whether they come in for walk-in versus same day or continuity, that they leave with the same high-level care for their overall health. We'd also like to improve internal education forums and holding ourselves accountable by improving the peer review process. So moving on to the next branch surrounding research, which is fitting since today is Quality and Research Day. In order to ensure that we're evaluating the research behind our practice, we need to look at the studies to see if A, they're set up to identify differences in race if they do exist, and B, to see if those are applicable to our patient population. And if not, then there are opportunities to partner with outside institutions so that we can conduct our own studies and be leaders in the field. Looking at the next branch, number 3, here's where we address the barriers and social determinants of health. So the main takeaway from this branch is community engagement and partnerships. If you leave with nothing else, just think of that. Although our clinics are in the community, we're not actively engaged. And so here, this is where we focus on doing needs assessments, identifying and leveraging resources, and advocacy on a local and national level.
1 minute.
The last branch is so important because it has to do with all of us. So we know that patients and their health outcomes are affected by who is providing the care. So not only do we need to strengthen our pipeline to hire the best and brightest underrepresented workforce, but we need to support them and provide ongoing training to meet and understand the needs of the community. So this slide right here is what I call our roadmap to achieving anti-racism care at Unity. So over time, by addressing these issues together, we can improve the health outcomes of not only our patients, but of DC and the patients in the district overall. Next slide. So I'd like to give a special thank you, first and foremost, to Dr. Boyd for being an amazing mentor and coach and pushing me behind my perceived limits. I've grown so much in this process, and I really appreciate her. Colleen for being a technology guru and keeping our thoughts organized while we have these planning sessions. Dr. Buchholz for his support and encouragement on my move to the Social Determinants of Health work group. Jeronica for listening to the staff and getting the conversation started. The Black Health Matters group for being a liberating space and supportive community. And then also the Social Determinants of Health and the GFR work groups for their countless hours working on the issues laid out. Next slide. And next slide. Does anybody have any questions?
Thank you so much, Krista. If you have any questions, please share them in the chat. It looks like a lot of people would like to have a copy of your roadmap. And there are a lot of agreed, and congratulations to you for a really enlightening presentation.
Thank you all. Yes, as we start to get these work groups going around these 4 branches of the tree, we will definitely be reaching out to people to see how you can join the cause and help with the change that we're going in.